Preserving Fertility on Steroids and Testosterone. That's the name of this video. This video is so timely as I'm seeing more and more patients coming in. They're young and they're on steroids or testosterone and they're having problems conceiving a child for the first time or maybe a second or third child. And this is something that doctors in the world are really seeing more too. And if this is becoming more mainstream, there's now upward of at least 4 million men in America using and have used steroids, and there's more experts out there, and I'm so happy to see it. I, of course, always like to use evidence-based guidelines and support for what I do as a physician. Physicians have to use evidence-based guidelines and evidence-based support and to guide us. We can't just think, well, that's great, let's just do it. We don't do that. We're always changing those studies, and we have to have our peers involved. So, but in the end, the anecdotal data, the anecdotal clinical being of what I am and what I've learned for years and years with thousands of patients is so important. That's why I'm giving. It's right here. It's going to be right here. So the first piece is I want to present the evidence-based support that I have tonight. What we have here is we have two journals, both Asian Journal of Andrology. It's interesting, it's the Asian Journal of Andrology. Why isn't it the American Journal of Andrology? These are American scientists. The most important, the 2016 May to June presentation, it's recovery of spermatogenesis following testosterone replacement therapy or anabolic androgenic steroid use. It's Doctors McBride and Coward. And these are Department of Urology, University of North Carolina School of Medicine, Chapel Hill. Right? Not schleps. Those are big guys. Next one is 2015, May, April, also Asian Journal of Andrology. Something's going on there. Preserving Fertility in the Hypogonadal Patient, an update. And this is Dr. Ramasamy and Dr. Armstrong and famous Dr. Larry Lipschultz. And these guys are at Baylor Department of Urology. So there it is. Now, I've been aware of these studies because they've been around for a couple of years now. And I've, of course, read them when they came out and I have reviewed them. And tonight, what I'm going to do is I'm going to give a synopsis and I'm going to integrate all the data in these studies. I've boiled down the data in these studies and I've made it simple and I've provided it here. This is a clinical bottom line. These are the clinical findings and the anecdotal issues and the experiences I've had with thousands of patients. I don't think anyone in the world has ever seen thousands of patients I have on steroids, and of course I'm an expert in taking care of men on testosterone because at the end of the day, most of these men obviously have to be transitioned to physiologic testosterone. So to start the presentation off, we have to understand always the physiology or the pathophysiology, and that is on men on steroids or testosterone. How do their brains relate to their testicles, and in the end, the fertility is diminished. So it all boils down and it all ends up where you have to understand this classic hypothalamus pituitary gonadal axis. There it is. Please allow me to use my schematic. I have to move fast, so it's a schematic. We have the brain. We have in the brain, the hypothalamus. We have the pituitary, the anterpituitary, and the testicles and testosterone. So this is a feedback system, a negative feedback system. It's like the heating, ventilation, air conditioning in your house or your office where you put it on 70 and cool. It's never going to stay there. It goes up to 70.5 and the chiller goes on. Then it brings it down to 69.5 and it goes off. And it lets it go on and off like this. That's how your brain works. It's very tightly fed back. There's a feedback loop that are incredible where there's just tight balances and where they're maintaining levels, and there's different there's hormones that are working throughout the body, and it's incredible. And this is very limited with our understanding. If you talk to the real experts, it's very limited. So the basis, and when we talk about this is going to be my model. So right off the bat, the primary area is actually the testicles. Those are the testicles and testosterone primary. Secondary is the pituitary, and tertiary is actually the brain, the hypothalamus. So the way it starts off is the brain itself releases gonadotropin, a releasing hormone that goes from the hypothalamus, from cortical overlay, from many other effects and circadian rhythms, and so many other pieces with depression and an intact man for his brain, the above, the cortical brain. And this releases GnRH, which stimulates the anterior pituitary to release the two classic gonadotropins, LH and FSH, luteinizing hormone and follicle stimulating hormone. The LH stimulates the Leydig cells, FSH, the Sertoli cells for semen, and the LH obviously is the Leydig, and that's testosterone. The feedback loop is your testosterone levels go up more in the morning, and it goes up and it swings up in the morning and it eases down in the day, but typically it stays quite normal, and that feeds back negatively and shuts down and slows down this GnRH because it feeds back negatively up on the hypothalamus and actually in the pituitary itself, and therefore you have this circadian rhythm that's undulating, and that's the intact man. And with this and for this, a man produces testosterone inherently and semen. And that's what it is. So this presentation is based on two features and two clinical features only. It's going to look at steroids. It's going to be restorative regimen, restoration regimen for how is a man on steroids or testosterone, how does he get fertile? Restoration regimen. And then there's a maintenance regimen for men just on testosterone. The last two steroids, because we don't know. I asked men on steroids to come off onto TRT, but if they want to maintain fertility. So let's get right into it. What type of hypogonadism do we see? We see a hypogonadotropic. That's why I have to have this hypogonadotropic. So we see a low hypogonadal the gonadotropins, LH and FSH. That's the type that it is with anabolic steroid-induced hypogonadism. When you do steroids, we figured this out now, that you're going to have an anabolic steroid-induced hypogonadal condition. It's for all sake of the diagram and for moving forward, because it's not a clean piece completely 100%. It's a secondary type. It's a hypogonadotropic. It's hypogonadism. You have low T, but what type? It's more the pituitary, because we know that the testicles, when you give these other agents, you stimulate the testicles, they'll respond. So that's not really a failure of the testicle, is it? It's really more of a failure in the pituitary and also on the brain. I feel it's very complicated. We're not even there yet. That will probably change in a few years from now. I'm sure it will. But we're pretty sure that the hypogonadotropic hypogonadal condition HH is really in the similar. It's the department, or it's the category that the ASH falls into. So with men that are using steroids, I'm going to go right to the clinical bottom line now. I'm just going to keep moving for you guys. I know you want this. Restorative regimen, they talked about many different drugs and different types of regimens. I boiled it all down. The way it works is you're going to stop steroids. Door number one, stop steroids. You can wait, stop steroids and wait. And it's amazing, the data shows that over time, men over longer periods, up to 2 years, maintain fertility and their testosterone can come back. We know this. But men don't come back so quick usually, and depending on who they are, how old they are, the steroid use, if it's really suppressive, what they've done, they're going to have to wait and suffer. So that's why we do this. And these doctors said that. They said you could wait, stop the steroids and wait. But they also said it's unethical. They did it. It's awesome. These are great. We're in a great place now. They said it's unethical because the patient's going to suffer. So We have data. We can help. HCG is the first medicine, the first agent to use. HCG, what's the dose? What's the delivery? 1,500 to 3,000 IUs every other day or for 3 to 6 months. 1,500 to 3,000. The studies said 3,000. I actually use less. I eyeball men and I make it that I work with the men and we get a feel for how much do we want to use. Do you really want to go to 3,000? And some urologists are going to see that number and say, what? They go right to 500. They don't even go, you're going to get side effects. This is what I'm presenting this for. The side effects. I'm not saying these guys did a bad job. This is their data. 3,000 worked. I think you could use the lowest possible dose to get the job done. So, you do this for 3 to 6 months. Most men, that's my regimen. It works. If it doesn't work in that time period, check a total testosterone, total and free testosterone, and estrogen level, and check a sperm analysis. Send them to urology. And if you're at urology, maybe move to another urologist. Maybe go to these guys. Maybe come to me. It's a big world now. More doctors are going to be doing this. So, that's the first regimen. You can keep doing it for up to a year. Next piece, if you have to add, I'm just boiling it down quick, Clomid. Clomid or FSH. And it's not HMG, we're going to get into it in the end. Clomid is a selective estrogen receptor modulator. It works by blocking the receptors of estrogen up in the hypothalamus, and that feedback loop obviously allows that blockade, and it increases GnRH, which leads to an increase in FSH. The amazing secret here that I've learned, that they said in the papers, and of course I've known this, and I think a lot of bro scientists know this, when you use too much HCG and too long, what happens? You decrease FSH. Initially, it goes up. Then it maybe downregulation. Too much HCG, you're going to downregulate and lower FSH. You're trying to get fertile sperm, FSH. That's a problem. Aha! So, add Clomid or recombinant FSH, follicotropin. 75 IUs every day or 150 IUs 3 times a week for the recombinant FSH. You could use human mammillary gonadotropin. We'll talk about why in the end, why you can't really find it around, although it is around, but it's hard to get. But HCG is still the gold standard. You don't need recombinant HCG over drill, but you could get it if you want the best of everything. That's the best. But this stuff works great. So that's it. That's the piece. Now, the side effects, that these are urologists, not that they don't care about internal medicine, and not that I am an internist and I don't care about urology. We're different doctors. We have different principal strengths. We work together. When you give that much of that medicine, what's going to happen? Oh, you'll get fluid overload. We don't even know why. The aromatization, estrogen goes up. Guys get puffy. They don't like it. They definitely don't like this. They don't feel so good. The brain's not as good as being on testosterone esters. These are secret pieces. But the guys will know this. The patients know it. Fluid overload. I had a patient have a heart attack. He was on HCG for a few months. He had cardiac risk factors. I don't think he was so good at maintaining and managing those risk factors with me and other doctors. He overloaded with fluid and he had a goddamn heart attack. So be careful. Be careful, doctors. Patients, be careful. Keep lowest possible dose, lowest frequency of time, and get in and get out. Cardiovascular disease, hypertension because of the overload, hypercoagulable state, changing lipid, bad lipid panel changes. Remember, the HDL goes down, the LDL goes up. Gynecomastia, right? Emotional, psychiatric overtones, DVTs, pulmonary embolism, downregulation, long term. Can we do it? I don't know. I don't like to do this stuff for too long. That's going to move us into the maintenance. Okay. So, the restoration is all about steroids, restoring fertility, short and sweet, get it done, move on. HCG is the basic. I would add Clomid, and I'm going to probably do this. I've learned, and I think I'm going to be doing this for some of my patients, in addition to saying to the urologist, I think HCG fails. I think Clomid, of course, check the sperm, check the studies. You can always check a CBC also, look at the vital signs, work with urology, potentially add Clomid or FSH, recombinant FSH. brilliant. This is going to work. This is going to work. And then sometimes if these things don't even work, you're just so suppressed, man. And it's pretty rare, but we do see it sometimes. Again, I leave the urology, fertility urology guys, I'll let them take care of this stuff. I just watch and help. Maintenance. You're on testosterone now. You're either a guy you're on testosterone, not a steroid user, or you're a steroid user and you're on testosterone. Both in the end come to the same, where you're living on physiologic testosterone, but you're young, so you want to maintain fertility. In these studies, in these amazing studies, the classic Baylor study from, I think, 2013 came out, and it said 500 IUs twice a week, maintained. It was 1 year, only 1 year. I've been around for 15 years with these men. I don't like to give these medicines for too long. Plus, you're going to get downregulation, you're going to get fluid overload. I don't like it. That's why I discourage it. But hey, I have some patients say, Doc, can we? Of course I can. Of course we can, but you're going to get downregulation. That's what I offer in my clinical services, man to man. But I have to start with evidence-based. And there was that one study. Just one study is not enough, though. And these guys know that. But it starts somewhere. So the two I say for maintenance on TRT, HCG, 250 to 500, 2 times a week or every other day. Right there. Done. Don't use Clomid. I got to keep moving here. Don't use Clomid. It's a warning if it's as a standalone agent. If you have a man with anabolic steroid-induced hypogonadism, a man's coming off steroids, you could use it certainly with a PCT. This is not PCT. This is fertility, okay, and maintenance with maintaining. Okay, this is not PCT. That's a whole other video. So, but it's obviously it's the same drugs, right? And it's the same kind of man, obviously, steroid related. So this, if a standalone agent for a steroid user, which is mainly the guys I see, they don't feel psychiatric. They don't feel good. They don't feel good. But then again, these guys didn't recommend to do it by itself. They it's an add-on agent. That's a different deal. So, but men that have standard TRT guys that organically have never used steroids, their brains haven't been exposed to androgens, they can feel good on it. I have got patients for years on Clomid. Maintain testosterone, fertility. Now these are guys that are older and they have children, so they don't care about fertility. But for this video, we're talking about fertility, so you get testosterone up and you maintain fertility. Incredible. Next piece, talking about all the drugs, just to be thorough, we have the serums, HCG analogs, we have not to mention HMG and FSH recombinant, and we have, of course, aromatase inhibitors. It's in their papers. It's kind of a tertiary add-on. I don't like it. You would add it on potentially for someone if your testosterone estrogen ratio is less than 10 to 1. That's obviously you have more estrogen and it's suppressing testosterone. That's going to affect over here. We know that there's studies on men that are intact men that are hypogonadal, typically older. They have ratios of estrogen to testosterone like this. And we can block the estrogen with aromatase inhibitors. Be careful because it has side effects. And we see a little bit of an increase in GnRH, and therefore testosterone goes up. It works like Clomid in that respect. It's incredible, like a selective estrogen receptor modulator. Again, no one's doing this. No one does that. It's just so no one does that. So they do this. Side effects, fluid overload. Boy, I talked about a hypertension, gyno. There's gynecomastia. I've seen DVTs, pulmonary embolisms. Downregulation, this could downregulate. You can't do this stuff for long term. Testosterone doesn't downregulate. It's amazing. It just doesn't. We don't know why. It just provides men to feel great for decades. But this stuff does downregulate. So you get in, you get out. You get in, you get out. You go HCG, you add either one of these, and that's how you get fertile. And you come on 6 months at a time. You got to be careful. Maintenance, interesting. Last piece is these experts, which I agree with them, say if you're on testosterone and you want to be fertile and you're young, 20s or 30s, which is crazy, but that's what we see now because probably from steroid use, obviously, that every once a year come off and run some of these regimens. And I offer that to men. They don't ever really want to do it. We just flip them when they're ready to get fertile for one of these regimens. That's the secret. That's what I do. And the experts agree with me, and that's what they do. That's what the urology guys do. Short and sweet. So the facts, interesting facts, HMG, postmenopausal urinary derivative from women, postmenopausal women versus HCG is pregnant women, That's interesting. There's a rare condition called a prion. It can be deadly with the central nervous system. Creutzfeldt-Jakob disease with HMG, believe it or not. This is rare stuff. It's just cool facts. And that's why it's off the market, I believe, and no one's really making it. Maybe one or two manufacturers, very hard to get. And we have the recombinant FSH preferred, is preferred. So and it's interesting that we use ACG because that is safe and effective and cheap, and it works great. But you could get the recombinant HCG. It's called Overdrill. Hope this helps men in the world and doctors to understand this. That are using steroids, not to use steroids because this is the stuff you'll have to do. And if you're on testosterone, you could do maintenance. You could, if you're young and maintenance, there's a way to do it. It's very complicated. You have to see an expert though, who obviously does this as a full-time job. And in my opinion, not just a urologist, those are great surgeons. Some of these guys obviously are great, do a great job. But the standard urologist probably won't. He's a great surgeon though. You want him to do surgery from the kidneys down. And endocrinology doctors are great. I see them more as experts in diabetes and thyroid. Some of them, again, are great on this, but with the time constraints, they don't get to study it like someone like myself or some of the other anabolic steroid experts in the world. I hope this helps. Thank you so much. Dr. Thomas O'Connor here. I'm glad you made it to the end of the video. If you liked it, hit the like button and please subscribe to our channel. And I look forward to bringing you more cool and interesting videos just like this in the future. Stay strong and healthy.